Rhonda Fellheim. We finished up our last discussion when we were focusing on this equation in this chart about the blood flow being directly related to change in pressure and indirectly related to the resistance of blood flow. And so we're going to look at some other types of influence on pressure and flow, and that would be the regulatory influences. Okay, we're going to talk about the regulation of blood pressure and flow. And as you can see, there's three main categories that we're going to discuss where we'll see significant influence in the flow of blood and blood pressure. So that would be local control, neural control, and hormonal control. Now, as you can see, we're going to start with local control, and I put the little icon down in the corner so you can kind of reference and see where we are at any given time among the three different areas. So let's start with local control. And again, we have three different items we're going to look at. For local control of blood pressure and flow, well, we've talked a great deal about vasoconstriction, vasodilation, and I think that you have a good understanding of what would happen to the blood flow in an area if the arterioles in that particular area vasodilated. Well, blood flow would increase to the area. And conversely with vasoconstriction, well, oftentimes in a very localized area, vasodilation and vasoconstriction will occur in response to chemicals that are in the fluids of the area. So we're talking here about pH, we're talking about waste, we're talking about decreased levels of oxygen. But again, it's very localized areas, and the blood flow in that area, or the pressure, can be influenced then on a very local level through what we call autoregulation. And a good example of this, I think, is when we start to exercise, it takes just a tad bit for our heart, our cardiovascular system to catch up with the increased activity of muscles. So say we have an area muscle, say you're getting ready to just run up the steps, like you're heading upstairs, and so you walk over to the steps and you're going to run up the steps. Well, that initial movement that you make, that initiation of that running up the steps, what will happen is you'll have vasodilation of the arterioles leading to the capillary beds of those muscles that are involved with that. And again, it's a very localized activity, and it's going to occur just until the cardiovascular system catches up. So it gives an opportunity for catch up there. Okay, moving on to vasoactive chemicals. Vasoactive chemicals, a couple of examples of that. A good example of that, a big example, is nitric oxide, NO. This is a real interesting chemical that's secreted from the endothelial cells, meaning the cells that will be in contact with the blood. So if blood pressure increases in a vessel and it pushes up against those endothelial cells, they will release a substance called nitric oxide. And this nitric oxide then is a vasodilator, and it will cause those vessels to vasodilate, which will reduce the pressure and increase the flow in that area. There are some other reasons that chemicals are released during trauma, infections. Again, exercise is involved, a good example. But last but not least, another local control would be angiogenesis. And angiogenesis is referring to the growth of new vessels in an area, possibly due to damaged vessels. From a pathology point of view, tumor growth needs a blood supply, and so we'll actually have the creation of new vessels, bringing blood, nutrients, oxygen to tumors, and so they often have a very complex blood supply of their own. In addition, if we have a damage to arterioles or vessels leading to an area of tissue, our body will often try to create a new route of vessels to make sure that the blood makes it to its destination. Okay, so those are the local controls. Okay, so let's take a look at neural control. When we're talking about neural control, and this picture should look very familiar to you. I've brought it up several times, but we're going to continue to look at the cardiovascular center. But this time you can see that I've exposed an additional set of nerves here that are on their way to blood vessels, and these nerves are called vasomotor nerves. Vasomotor nerves. So they're actually coming from the vasomotor center of the cardiovascular center. So the cardiovascular center, as we know, is going to influence heart through the vagus nerves, influence heart through cardioaccelerator nerves, and now we also know that there's this vasomotor center at the cardiovascular center that's going to influence blood vessels through the vasomotor nerves. Now, just a reminder, this cardiovascular center, where is it located? Here's my pons, here's my medulla. All right, okay, so that's in the medulla oblongata. Say it with me, medulla oblongata. Isn't that fun to say? Okay, anyway, neural control. So let's look at vasomotor nerves are heading out to blood vessels, and they carry sympathetic innervation. Sympathetic only. So when vessels are stimulated by the vasomotor nerves, they will always vasoconstrict. So we're saying that sympathetic through the vasomotor nerves, you will always have vasoconstriction. And see this nice big white box here with blue lettering. Vasomotor equals sympathetic equal vasoconstriction. And so if you think about this, what we're talking about is if there is a great deal of vasomotor influence, you're going to have a significant amount of vasoconstriction of that vessel. However, if you back that off, if you start decreasing the amount of vasomotor nerve innervation, you back it off, then that vessel will vasodilate. So it's the presence of the sympathetic influence which will cause the vessel to vasoconstrict. It's the absence that will leave it to vasodilate. Okay, so we know though from previously discussing neural influence on blood pressure and heart rate and contractility, we know that there are a number of different influences that are playing on or influencing the cardiovascular center. And I just want to remind you of those. Here are our autonomic reflexes, and these are going to be integrated as well at the vasomotor center. And we talked about the baroreflexes, we talked about chemoreflexes, and I just want to add medullary ischemic reflex at this point. And the medullary ischemic reflex, what that is, we have receptors in the brainstem, and they're assessing the oxygen levels and chemical levels in the cerebral spinal fluid. So in response to information about the cerebral spinal fluid, we could then vasodilate or vasoconstrict blood flow to the brain. Now, we know that we really don't change the blood flow to the brain a whole lot in any way, but in response to baroreceptor feedback, chemoreceptor feedback, and medullary ischemic reflex, we may very well have some modification in order to maintain homeostasis, and this would involve vasoconstriction or vasodilation of the vessels to the brain. Okay, so this is our neural control, and we're going to move on now to hormonal control. Again, we're talking about the influence that hormones have on blood pressure and flow. Okay, so we know that epinephrine and norepinephrine, when we talk about them as being hormones, just a reminder, they're coming from the adrenal medulla in response to sympathetic stimulation. They are hormones, they're released into the blood, and they will be involved in a sympathetic response. So they will act in conjunction with the nervous portion of the sympathetic system. Again, turbocharging that activity in the system, as well as giving it some endurance. Before we move on to the other substances listed here and how they influence blood pressure and flow, I think it'd be good to be reminded right now of what it is that creates blood pressure. What we're talking about when we talk about blood pressure. Well, I'm sure that you can all tell me that blood pressure is the push that blood has against the wall of a vessel. I mean, we measure that, and that's blood pressure. So if the pressure of the blood against the wall of the vessel, so we know what influences the volume of blood, because clearly the more blood you have, the greater the pressure is going to be pushing against the wall of the vessel. So we know that what influences that volume of blood is the amount of water that's in the plasma of the blood. The amount of water. So the more water you have, the greater the pressure against the wall of the vessel. So if you could just imagine this, if you were to increase the water volume in blood, then you would think, okay, then blood pressure would be increased. Or if you decrease the volume of water in the plasma, then you could think, okay, well, that would decrease blood pressure because it would decrease the pressure that the blood is placing against the walls of the vessels. Okay, so with that in mind, let's go on and talk about the remainder of these substances and how they influence blood pressure and blood flow. I'm going to skip to the next slide and talk about angiotensin II and aldosterone because they actually coexist in a sequence of events, and I'm going to talk about that first and then come back to talk about the last two. So we're still talking about hormonal control, and in order to talk about this sequence of events that includes angiotensin II and aldosterone, I want to paint the big picture for you. It's called the RAA, the renin-angiotensin aldosterone cascade or sequence. Okay, so first let me give you an idea of what we're looking at here. These two large purple structures are kidneys. These two smaller structures on top of the kidneys are the adrenal glands. And over here we have our lungs. The gray structures are our lungs. And so here's how this works. If we're looking at the kidneys, and the kidneys are just these amazing, amazing organs that we're going to discuss all of this again in great detail when we talk about the urinary system. But for now, let's give this a run through and see how you do with it. Okay, at the kidneys have receptors that will detect low blood pressure and low blood sodium. So let's just say these kidneys detected low blood pressure. Well, we already know, how could we possibly increase blood pressure? Well, let's take the steps through this and see what happens in the end. So we're in response to low blood pressure, the kidney will release a substance called renin. Renin. Now, in the blood already, we will have this inactive substance called angiotensinogen. And so when renin joins angiotensinogen in the blood, it will be converted to angiotensin 1. In the presence of angiotensin 1 in the blood, the lungs will release an enzyme called ACE, which is angiotensin converting enzyme. ACE. All right. So the presence of angiotensin converting enzyme then will convert angiotensin 1 to angiotensin 2. Now we say that angiotensin 2 is a potent vasoconstrictor all its own. In other words, it's going to cause vessels to vasoconstrict. Well, in response to low blood pressure, this would probably be a good thing because it would bring blood pressure up, wouldn't it? If we vasoconstrict an area, it will increase the blood pressure. So we'll have vasoconstriction taking place. But that's not the end of the story. Angiotensin 2, look, see how it makes its way to the adrenal cortex. In other words, the cortex of the adrenal glands, both of them. Okay? And within the cortex of the adrenal glands, there are specialized cells that in response to being stimulated by angiotensin 2, these specialized cells will produce and secrete a substance called aldosterone. This is a hormone, aldosterone. So aldosterone is going to go back to the kidneys, and it's going to have the final influence in this sequence of events on the kidneys. So if what was started, this whole sequence of events started out in response to low blood pressure, then obviously what we want to do is increase blood pressure. So what can we do at the kidneys to increase systemic blood pressure? What can we do? Well, right. We can say to the kidney, we need for you to retain water. In other words, we need for you to let water be returned to the blood, the plasma, instead of being a part of the urine. And so if we have the cells of the kidney return the water to the blood, then it would increase blood volume, hence increase blood pressure. The mechanism that the kidneys use in this situation in order to get that water to move back into the blood vessels is that the movement of sodium. Okay, through the movement of sodium. So the kidneys will orchestrate having sodium move into the blood vessels, water will follow, which will obviously decrease the volume of urine, but increase the volume of blood plasma, which will in turn increase blood pressure. So in the end. Okay, so what I would suggest you do is go back through this slide and make a list. Start here with 1. The kidneys detect low blood pressure and low sodium. I would start there. And I would say number 1. And then I would say number 2, the kidneys release renin. Okay, and I would make a list numbering each step so that you can associate the RAA with both angiotensin 2 and aldosterone and the influence that they have on blood pressure as being they are secreted in response to low blood pressure, and the end result will be that they increase blood pressure. Okay. So if we look back at our box for hormonal control of blood pressure and flow, we still have 2 remaining hormones that we want to talk about. Let's look at antidiuretic hormone. Antidiuretic hormone. Well, that name just by itself should tell you what its action is, because we know. Let me just put it in question form. What does a diuretic do? What does a diuretic do? Right. It makes you urinate. It makes you create urine and then get rid of it. Okay. So you'll find yourself urinating more. Well, how about if we say antidiuretic? Then obviously, what this hormone is going to do is to decrease the amount of urine that's being secreted. Okay, well let's look at this antidiuretic hormone. This is a hormone that's released from the posterior pituitary gland in response to low blood pressure. Low blood pressure, and you probably could have told me that, because if the action of this hormone is to decrease the amount of urine we produce, antidiuretic, then where is that water going to go? It has no place else to go but stay in the blood. Okay, so that would remain in the blood. So antidiuretic hormone then is released in response to low blood pressure, goes to the kidneys, to receptor sites on specialized kidney cells, and it will instruct those cells to please let the bring the fluid back into the plasma, put it back in the blood, increase blood volume, increase blood pressure. Okay, that's ADH. Now, so far, let's see. Aldosterone, angiotensin II, aldosterone, and ADH. These are all produced in response to low blood pressure. The only hormone we're going to talk about right now that influences blood pressure in the other direction is atrial natriuretic peptide. This is a hormone that's released from specialized endocrine cells in the right atrium in response to high blood pressure. Okay, so ANP is released in response to high blood pressure. This is the only hormone we're talking about that's released in response to high blood pressure. And again, it's going to go to the kidneys, act on specialized cells, bind to special receptor sites there, and it will encourage those cells to remove sodium from the blood, from the plasma. Water will follow, and so it will increase the volume of urine, decreasing the volume of blood. If we decrease the volume of blood, we're going to decrease the pressure of blood. So I would strongly recommend you go through these hormones and see if you can explain the action of each one in terms of blood volume. That's kind of the key to understanding them. Okay, that's the end of this particular discussion. So I'm going to close for now.